Alterations in pulmonary function. This lecture will be in 3 parts. On the left, it shows the normal respiratory structures that we use from the nose and the mouth all the way down to the alveolus, and on the right, it shows the functional unit of respirations, which is the alveoli. Lovely. Normal anatomy and physiology. On the off chance it's been a little while since you've done this, we'll have another brief review. The respiratory system performs 2 separate functions: ventilation and respiration. Ventilation is the mechanical movement of gas or air into and out of the lungs. Respiration is the exchange of oxygen and carbon dioxide during cellular metabolism. Effective gas exchange depends upon approximately even distribution of gas, which is ventilation, and blood, which is perfusion, in all portions of the lung. Dyspnea means you don't have enough air. You're short of breath, you have air hunger, you may have labored breathing. It's often associated with diffuse and extensive pulmonary disease. Symptoms are flared nostrils and use of accessory muscles. It's due to disturbances in ventilation and or gas exchange. It increases the work of breathing, and it's diseases that severely damage lung tissue can cause dyspnea. There are different types. DOE is not a deer in your headlights. It's the dyspnea on exertion. It has an increased demand and decreased supply of oxygen. Orthopnea is positional dyspnea due to redistribution of water, decreased muscle effectiveness, and the abdomen pressing on the diaphragm. PND is paroxysmal nocturnal dyspnea, and this is due to water redistribution. So if you have edema in your feet and you lay down at night, eventually that water is redistributed up toward the lungs due to gravity or changes in gravity, and that will cause dyspnea during the night. And this is from the memory book. It's showing 6 P's of dyspnea, things that can cause dyspnea: possible foreign body, pulmonary embolism, pneumonia, pump failure, or heart failure, pneumothorax, or pulmonary bronchial constriction. There are different abnormal breathing patterns. Now remember that normal breathing is eupnea, E-U-P-N-E-A. EU meaning normal, P-N-E-A having to do with breathing. So it's your normal respirations, average about 6 to 16. 20 is the top normal. Anything over 20 is abnormal. Kussmaul's respirations are an increased rate and depth with no pause in respirations due to metabolic acidosis and or exercise. Labored breathing is an increase in tidal volume and effort. Decrease in rate. Prolonged inspiration or expiration may be noted. Tends to occur if you run a distance, possibly. Obstructed. When you have obstructed respirations, you have stridor. Stridor is a high-pitched sound that occurs during inspiration. It's like a type sound. And please don't ask me to do that again, because that kind of hurts. You may hear a whistling or a wheezing sound. Tachypnea means you have respirations greater than 20. Gasping respirations are an irregular respiration. It's slow, with quick expiratory pauses that are noted. It's usually due to shock or cerebral hypoxia. Cheyne-Stokes, cerebral hypoxia, the brain's not getting enough oxygen. Cheyne-Stokes respirations are due to a decrease in blood flow to the brainstem and or neurological impairment above the brainstem. You tend to have alternating deep and shallow respirations with periods of no breathing at all, or apnea. A meaning without, and P-N-E-A meaning breathing, so without breathing. Oftentimes Cheyne-Stokes occurs before the final event, just before somebody dies. Panting tends to occur with exercise and kind of goes along with labored breathing. At least it does for me when I exercise. And this is just showing some of the different respiratory patterns that are different. Kussmaul's respirations, again, deep and labored. Get an acetone or fruity breath sounds odor, remember it's rotten fruit. It's not healthy fruit. Cheyenne-Stokes, tachycardia, Biot's respirations are very irregular. Hypoventilation is a decreased alveolar ventilation in relation to your metabolic demand. Some of the causes are severe hypercapnia. In other words, you have a very high PaCO2 level. Remember, your PaCO2, CO2 vasodilates. So you'd have somebody who's very ruddy in color with hyperventilation. It's due to an alteration in your neurologic or your pulmonary mechanisms. If it's severe hypoventilation, you're going to have hypercapnia, which is retained CO2, somnolence, which means you're really sleepy, and a decreased level of consciousness. Hyperventilation, it's when you have an increased alveolar ventilation with a decrease in demand. This will cause hypocapnia or a low PaCO2. You'll be blowing off respirations. So you'll have rapid, shallow respirations type thing. That's usually due to anxiety, could be due to a head injury or hypoxemia. A cough is a normal protective reflex. It's initiated by stimulation of an irritant receptor. So if you inhale a foreign particle or foreign body, accumulation of mucus or inflammation, all those are protective coughs that you have. And you should take a deep breath and cough as you exhale and then expectorate it or spit it out. I don't want to swallow it because all that'll do is get into your stomach and lots of mucus there. You won't have any appetite. It's really not, and it's not aesthetically pleasing at all. There are different types of cough though. You've got abnormal versus normal. And you've got persistent non-productive dry cough is abnormal. It can be due to a tumor, congestion, bronchitis, or pneumonia. If it's productive, it means you have an infection, particularly if it's with purulent sputum. If it's a productive and it's not purulent, just clear yellow or clear light yellow, you probably have too much fluid on board. If it's green, it's Pseudomonas, because the color will indicate the type of organism that initiates the problem. If it's hemoptysis, the sputum will be tested. It'll be alkaline. It'll be bright red and frothy in nature. But in order to determine if it's hemoptysis or hematemesis, you have got to check the pH. You cannot assume just because it's frothy that it's from the lungs. Somebody could have just had a soda and then decided to throw up blood from the stomach. So you have to check the pH. If it's in the lungs, it's alkaline. If it's from the stomach, it's acid. Hemoptysis occurs with tuberculosis. If you have an abscess, cancer, pulmonary infarction, bronchiectasis, or bronchitis. So it's really important that as the nurse, we note the changes in the amount, the consistency, and the characteristics of the sputum for progression of the disease and or effectiveness of therapy. We hope it's getting better, so we have to know. This is looking at different lung sounds that you might have. Crackles, current term, old term, rails. Rhonchi and wheezes. Rhonchi are loud sounds like a snore. If you have them take a deep breath in and cough, it should clear. That'll tell you it's a rhonchi. It's in the major airways. Crackles tends to be in the alveoli, fluid that's there. It indicates too much fluid. Remember, by the time you hear crackles, the patient has gained probably 10 pounds of water weight because that's when they start to third space that fluid. So crackles is not the first sign of fluid volume excess. Cyanosis is a bluish color to the skin and the mucous membranes. It's due to a decrease in your PaO2 and a decrease in your cardiac output. Could be due to a right to left shunt or low hemoglobin, or somebody who's really cold so they've vasoconstricted peripherally, or has a lot of anxiety where they've vasoconstricted peripherally because of the increase in catecholamines. There are two types of cyanosis. Central cyanosis is due to a decreased oxygen saturation of the hemoglobin. So in other words, you're not getting enough oxygen in to circulate. And you'll notice that in your tongue, your lips, and in the mucosa. Peripheral cyanosis is due to a decrease in the blood flow to a tissue. And you'll notice that in your ears, your nose, and your nail beds. There's pain associated with the respiratory system also, and it could be that you have someone who has pleural pain. Pleural pain is greater on inspiration with stretching of that respiratory mucosa, respiratory muscles, and it tends to be localized. If it's in the airways, it's due to infection and inflammation, and the chest wall is due to muscle or rib pain from either coughing or fractures. You can have clubbing of your distal digits, and clubbing can be due to a decrease in oxygenation and or the diseases that interfere with oxygenation, such as lung cancer, bronchiectasis, cystic fibrosis, pulmonary fibrosis, a decreased cardiac output, lung abscess, or coronary heart disease. And it's really easy to look at clubbing if you take your opposite digits and put them together. Say you put your two index fingers together. You should be able to see a baseball diamond at the junction of your first joint and your nail. If you don't see a baseball diamond there, that junction is starting to flatten out, and that is because the distal digits, tips of your fingers and or toes, because you can do it with your toes also, but it's really hard to get your feet face to face, are not getting enough oxygen. And if you smoke, you should probably do that on a weekly basis to make sure you're not causing permanent injury to your body. Hypoxemia means you have a decrease in oxygen in the blood, your PaO2, and hypoxia is a decrease in oxygen in the tissues. And this is from the memory book. Oh, I'm sorry. This is a slide that I have that shows a normal digit on the top and clubbing of the digit down below. You can see that junction starts to flatten out. This is one showing hypoxia, inadequate oxygen for cellular metabolism, talks about some nursing interventions that you might do, risk factors for, and treatment thereof, and symptoms associated with it. And here again are some symptoms of hypoxia from the memory book, just to kind of help figure out some of that stuff. And you can see it's a little bit different when you're talking about pediatrics, because you'll have a feeding difficulty, inspiratory stridor, and grunting, sternal retractions. Hypoxemia could be due to an abnormal ventilation perfusion ratio, and an abnormal ventilation perfusion ratio is the most common cause. This can occur if you have somebody who has asthma, because that causes bronchial constrictions, or if they have pneumonia or pulmonary edema, because that will cause an increase in fluid in the alveoli, and that will decrease ventilation perfusion, because your perfusion will be a lot better than your ventilation. Or it could be because of an increase in ventilation perfusion, which occurs with pulmonary emboli, because your ventilation will be better than your perfusion in that instance. It could be due to a decrease in the oxygen content in your inspired air. Say you decided to climb Pikes Peak, or somebody put a plastic bag over your head. The latter is not to be tested in any way, shape, or form. Hypoventilation, again, you don't have enough oxygen, you're not breathing as deeply, and this occurs with chronic obstructive pulmonary disease. You could have a decreased stimulation of your respiratory center, and this occurs if you have somebody who is using narcotic drugs or illegal drugs, or has overdosed on one of those drugs, or if you have somebody who's had a stroke. You could have a diffusion problem if you have a thickened alveolar capillary membrane. For somebody who has fibrosis or edema, you're not going to get as much of an oxygen exchange. Or if you have a decrease in the surface area, which occurs if you have COPD, of surface area that's capable of exchanging gases. You could have a pulmonary right to left shunt, which occurs, causes a decrease in oxygenation, and this occurs with acute respiratory distress syndrome, or acute lung injury is the current phrase for that. Or atelectasis can cause hypoxemia, because that gives you an alveoli that's not capable of exchanging gas. Acute respiratory failure is when your PaCO2 is greater than or equal to 50, your PaO2 is less than or equal to 50, and your pH is less than or equal to 7.25. This can be due to direct injury to the lung, the airway, the chest wall, or due to injury to the brain or spinal cord. If you have an increase in PaCO2 due to a decrease in alveolar ventilation, you may need ventilatory support. If your pH is less than 0.72, you probably need to be on a ventilator if your problem is purely respiratory. If you have a decrease in your PaO2 due to a decreased exchange, you'll need to receive supplemental O2 in some fashion. And again, you may need to be on a ventilator. Keep in mind, if you have a chronic lung disease, you do not want to infuse O2 at greater than 2 liters per minute without a physician's order because it will eliminate their respiratory drive. Acute respiratory failure could also be due to a complication of surgery. Atelectasis, pneumonia, pulmonary edema, and pulmonary emboli can all cause acute respiratory failure. Risk factors for acute respiratory failure are, again, smokers, someone with a decrease in cardiac reserve, someone with chronic renal failure, chronic hepatic disease, or if they have an infection. I like cartoons. This is showing some of the hazards of smoking. We have Sir Rodney, who apprehends public enemy number 1. And the guy down below says, whose right was it to make enemas public? That's enemies. We caught this man cheating. So? He was stealing from the people. So? And lying about it. So? Not a big deal, obviously, to the king of Id. And he also smokes. Off with his stinking head. This is showing some of the possible smoking benefits. On the left, we have a hospital where we have Medicaid expense due to smoking. And on the right, we have Social Security benefit savings due to smoking, because as you can see, we have a cemetery. Because smoking will kill. Pulmonary edema. You'll have increased water in the lungs. Could be a possibility. Some of the causes are, because increased water in the lungs is pulmonary edema. You got lots of fluid in the alveoli. Causes. Heart disease, because left ventricular failure causes increased pulmonary capillary hydrostatic pressure, which results in fluid going into the interstitial spaces. Capillary injury occurs with acute lung injury that causes increased permeability with protein causing third spacing of fluid into the alveoli. Or obstruction of the lymph system due to tumors, edema, fibrosis, or an increase in your systemic venous pressure. Symptoms: crackles, dyspnea, pink frothy sputum, hypoxemia, decreased oxygen in the blood, hypercapnia, increased CO2. And your sputum will look like beaten egg whites. Really frothy looking. This is showing the pathogenesis of pulmonary edema, where you have valvular dysfunction, coronary artery disease, or left ventricular function on the far left, left ventricular dysfunction on the far left, causes an increase in left atrial pressure, causes an increase in pulmonary capillary hydrostatic pressure, causes pulmonary edema. Or it could be injury to the capillary endothelium that causes an increase in capillary permeability and disruption of the surfactant production by alveoli, because surfactant is important to keep your alveoli open. Causes movement of fluid and plasma proteins from your capillary to your interstitial spaces and the alveoli, again, pulmonary edema. Or it could be blockage of your lymphatic vessels that makes it impossible to remove excess fluid from the interstitial spaces. So fluid collects there and causes pulmonary edema. The memory book gives you a regimen to treat pulmonary edema, morphine because it causes a decrease in peripheral vascular resistance, so fluid pulls away from the lungs and pools in the extremities. It also decreases their anxiety. Make sure their airway is open. DIG, usually because they're very tacky, and this will help increase their contractility. Diuretics, oxygen, and blood gases. Not necessarily in that order. That's just a way to remember it. Aspiration. Aspiration occurs when you have passage of solid particles or fluids that go into the lungs. The usual cause is impaired swallowing or an impaired cough reflex. It will result in collapse of the airways distal to the obstruction. It is a heck of a lot easier to prevent than it is to treat. That's why you do not feed people lying flat on their back. You do not give them liquids lying flat on their back. You make them turn to their side, or you elevate the head of the bed. It tends to occur more often in the right lower lobe because of the branching angle of the right main stem. It's a lot straighter than on the left, and so it's a whole lot easier to go in there. It can also be due to causes of impaired swallowing, by the way, could be due to a change in your level of consciousness, stroke, or CNS abnormality of some sort. But when somebody aspirates, they initiate the inflammatory response. And if they develop aspiration pneumonia, 50% will die. Because aspiration of gastric fluid, keep in mind that pH is less than 2.5. And the pH in the lungs is alkaline. So this aspiration of gastric fluid will cause severe pneumonitis, or inflammation of the lungs, with inflammation and loss of ciliary function and bronchospasms, leading to hemorrhagic pneumonitis. It will decrease the surfactant, so they end up with what's called a stiff lung. It's impossible to ventilate. Symptoms are cough, they'll have choking, vomiting, wheezing, and dyspnea. Atelectasis is collapse of lung tissue. Its symptoms are similar to pulmonary infection. You'll have dyspnea, cough, fever, and an elevated white blood cell count. Compression atelectasis may be due to tumors, fluid, or air in the pleural space, or the abdomen pushing on the lung. Absorption atelectasis usually occurs postoperatively from anesthetic agents, or it can be due to obstruction or hypoventilation of the alveoli. Bronchiectasis is the persistent abnormal dilatation of the bronchi. It is associated with recurrent respiratory infections. It's also associated with bronchitis and atelectasis. Symptoms are copious, purulent sputum, hemoptysis, clubbing of the digits, and cora pulmonale. Pleural abnormalities might be a pneumothorax. There are different types. You can have an open or communicating pneumothorax. I'm going to stop here for part 1, and we'll continue this with part 2. So we'll resume with pneumothorax on part 2.